Thank you very much, Dr. Hany Hafez, for giving me this privilege of having a lecture tonight, because I'm supposed to try to revise in the next 30 minutes what happened in the different nephrology congresses and transplantation congresses in the last year, 2015. I will divide my talk into two parts. The first part will be speaking about basic and clinical transplantation, and we'll review together the following 9 items: the dendritic cells and innate immunity, how to monitor adequate immunosuppression, what are the biomarkers of clinical significance, is subclinical rejection a matter for treatment or not, is delayed graft function an issue nowadays in 2015-16 or not, what are the new immunosuppressants in the pipeline, what is the status of art of cell therapy, and how can technology improve patient outcome, and transplantation of octogenarians, people in the 80s of their life. And then we go to other parts. Let's start with the first part, which is the dendritic cells and innate immunity in kidney transplantation. And this article by Prof in Kidney International in April 2015 shows that there is a very important primary role of recipient dendritic cells rather than donor in rejection. And it also recognizes the allogenic non-self by host monocytes, and this is followed by their differentiation into mature dendritic cells, antigen presenting and leading to rejection. So, in the future, there will be possible treatment option of addressed to, targeted to monocytes or to dendritic cells, and this will be very important. The second item is adequate immunosuppression. I mean finding a safe place between the hammer of over immunosuppression leading to malignancy and infection, and anvil or sindan of under immunosuppression leading to rejection. And this was a big review article in Kidney International, revising the factor influencing the position of these limits, which are listed in the left part of this slide. And these are the available assays for immune monitoring to put the patient in the proper immunosuppression state. Some of them, you know them since long time, like the immunotest, for example. And some of them are getting importance nowadays, like the interferon gamma, ELISpot test, panel of reactive T-cell interferon enzyme-linked immunoabsorption assay, and the natural killer cells. And then I will go for these in details in the next slide. Some of them are very long-standing, like the renal graft biopsy, but some of them are new methods to look to the biopsy, as I will mention later on. Let's revise this interferon gamma, ELISpot test, and natural killer function to see how by this test we can anticipate that our patient will get malignancy or is over immunosuppressed. And in this article by Christopher Hope et al., they found that patients who have current cancer or are prone to metastatic cancer have the lowest level of interferon gamma and the lowest level of natural killer cells. And this was persistent whether they take 3 drugs or whether they take MLF or whether they take CNIs. So these tests, very simple tests, can tell us this patient can have later on malignancy or high tendency for malignancy. And this is the one that I just mentioned, the ELISpot test. And another test, which is the real-time PCR for rejection or tolerance signature. I will go for it. And there is now a bundle of 17 genes, but by a study called the Keysort study, they found that this 17 gene is a non-invasive way for monitoring renal transplant rejection without discriminating between cell-mediated and antibody-mediated immune rejection. And this 17 gene is very important because it detects the rejection 3 to 4 months before current diagnostic tools, which are the creatinine and the biopsy. And by the way, it has been marketed in the United States. I mean, this test is available on a marketplace. The key sort is same. So this is the second test. The third test is the flow cytometry for different E, B, and isotypes of the different antibodies. I will go for it in details. The fourth test, Dr. Gamal Saadi spoke about it yesterday, which is the epigenetic with special methylation of FOXP3 and PH17, and I will elaborate a little bit later about it. The fifth test group is the ligand assay. We are all of us acquainted of measuring different cytokines as markers of rejection. For example, the urinary IP10. This is another molecular signature published in the Journal of American Society of Nephrology last year, and giving the value of molecular microscopy to detect early antibody-mediated rejection, and this, they call it this molecular score, reclassify the risk for allograft failure into high-risk and low-risk patients. And by this heat map is colored by threshold representing the histological characteristics of patients with antibody-mediated rejection versus those who don't, and comparing this with the classic band classification and showing some superiority to this heat map on the histopathology, and it has been published last year. This is a very important new piece of information presented by the French group in Brussels in the ESOT of 2015. They studied 125 cases and show the failed graft in 19 of them. And they found very high hazard ratio by the C1q binding capacity, 6.2. So this is, I think, if you look at here, this is a very recent piece of evidence showing the importance of the C1q test. Although that there are some reports against, but this is mid-2015. And again, they showed that IgG3 have a hazard ratio of 7.4 for the incidence of acute antibody-mediated rejection, and Dr. Gamal Saadi mentioned this yesterday. And the IgG4 is associated with subclinical antibody-mediated rejection. So by just making these antibodies and classifying them in this way, we can anticipate if the patient will get antibody-mediated rejection or subclinical rejection or resistant rejection. This, I call it the CIA, to remember it. CIA, Computer Assisted Inflammation Analysis. And this has been presented by Antoine Sicard from Lyon, showing in the biopsy, I will do something different. I will double immunostain for the capillaries by CD34, and then I will make numerization of the graft and color the composition, the nuclei in blue, the cytoplasm in red, the capillaries in brown, and the humans in white. And then color coupling, and after that, you get this very nice picture topographic quantification of the graft. So is this just for getting beautiful colors? You can see the Picasso, and we don't need to do this. No, the value of it for this is to quantify the antibody-mediated rejection in the kidney recipient by an objective way. So there is correlation between the cell number and the graft survival. And in these 52 biopsies between 2005 and 2012 in Lyon, they divided the patient into 2 groups according to the median number of cells. And please look to this CD68, which is a marker of the monocyte macrophage. Those who got low number of monocyte macrophage got only hazard ratio of 1 to get rejection. But those who get monocyte macrophage in big quantity, they got 3 times the risk for getting rejection. So the hazard ratio here is 3.1 and 2.6 successively. So you see how this CIA is very clever. And for this cleverness of the CIA, they added another test. You know that this group published Sikaritel last year that the C3D could be more beneficial than the C1Q in assessing the risk for rejection. As you see here, those which are C3D positive have a graft survival which is far superior than those, the negative have a graft survival which is better, and the C3D positive has a worse graft survival. So they suggested they should add this new marker that they just found, which is the CD68, to potentiate the accuracy of the C3D test. So what they did, you see here, those patients with DSA C3D negative have the best survival. C3D positive and CD68 low, intermediate survival, and CD3 positive and CD68 positive, I mean they have the complements and they have the monocyte and macrophage, so they have the worst graft survival. And this is the state of art of integration of the C3D assay with the CD68 by the CIA microscopy. What about an opposite marker, which is called the serum Dick-Kopf related protein, or the summary is DKK1. This renal allograft fibrosis marker was inversely associated with graft failure. So this is the first human data presented in last American Society of Nephrology on a big number of patients, and showing that those patients having this marker have long-term protection against graft failure. So this is a protective marker rather than a negative marker. So now I finished the third part of my talk, and now the fourth is the subclinical rejection. Is it important to treat? Yes. The state of art now stresses the role of subclinical rejection and the contribution to fibrosis by validating 11 gene sets. And there is a growing evidence that subclinical rejection leads to long-term graft injury. Ability to detect subclinical rejection may improve the graft survival by allowing early intervention. And in this comparison between all the studies that address subclinical rejection, published in 2015, you see that the prevalence is around from 30%. In some studies it is less, and in some studies it is higher, and it is totally associated with the IFTA in most of the studies, and with the graft loss in many studies. So our conclusion for this is that subclinical rejection, including borderline, occurs in 30% of the biopsies, 3, 12, and 24 months, and is ongoing in about 50% of patients, and is associated with fibrosis at 12 months, and the gene expression profile identify the patients. What are the value for this? The value is that we may have some molecular diagnostics that identify the risk for graft dysfunction before the histological changes. This has been published in international by this Czech group, and they found that these markers, the CLE, C5a, and the FGA, if they are high, by immunohistochemical stain, they differentiate those patients with prone for subclinical rejection from those who are not. You see here these anti-CLA and B. This is one slide comparison, and this is the second comparison. Here, all the slide is black, and here you see these green spots indicating the antifibrinogen antibody. What about the state of delayed graft function nowadays? in 2015. This longitudinal study for 12 years follow-up found by this group found that delayed graft function remains an important risk factor as defined by the need for dialysis once in the week following the transplantation. And it is in this contemporary cohort of kidney transplant recipients, intervention to reduce the risk or its after effect remain of paramount importance to improve the kidney transplant outcome. And it correlates well, according to this New England Journal of Medicine publication, with the states of hypothermia that we do for the, of course, this is cadaveric. So if we make perfusion before the harvesting of the organ at 37 degrees normothermic, we get worse prognosis than if we do at 35 degrees when we have hypothermia. This has got a less incidence of delayed graft function. What is the predictive value of delayed graft function calculators in kidney transplantation? This has been presented in the EDITA in London by this Belgian group, comparing three markers, three sets. They found that the rate of TGF in the study is 15.3%, and they compared this 18-parameter marker of Ireland with the TGF score of Chapal et al., and they found that this Irish logogram shows good predictive value at the population level, but it has little positive and negative predictive value in individual patients. What about the new immunosuppressives in the pipeline? These were promising, but efanesumab had got safety concern. These have been withdrawn, FKC 778, alifacet, voclosporin, maybe in lupus, soprasporin, maybe in lymphoma, FTY in multiple sclerosis, alemtuzumab in multiple sclerosis, and of course it is more beneficial for the pharmaceutical company to market it in multiple sclerosis, to facilitate also in rheumatology. But we, according to Christophe Legendre in the ESOT, he summarized in his presentation the state of phase 3, phase 2, phase 1 preclinical research and discovery for the molecules in the pipeline. 4 in the discovery, 9 preclinical research, and this is a secret. But the phase 1, we know that GM-CSF, C1s in Treg cells, anti-CD28, and carbon monox. Among the 19 in phase 2, some address the complement, like the anti-C5, which is in both phase 2 and in phase 3. Some of them address the ischemia reperfusion, like the anti-TOL-like receptor 2, the custodial N, the cardiotrophine 1, and the tiprelostat, and some miscellaneous like the anti-CD40 and the belimumab. Those in phase 3, we know some of them because all of us, we practice using rituximab, everolimus, and the anti-C5, but there are some ongoing more studies to prove their value, in addition to the HGG and the IVIG and the peg-carbohemoglobin. Are there any protocols for sensitized deceased donor? And yesterday, Dr. Kamal Okasha gave this talk very nicely. I will just give 2 slides, 2 very recent slides in this. The study by Glotz et al., presented in the last American Society of Nephrology, giving to eculizumab, which is a very expensive drug, at day 1, 7, 14, 21, and 28, and then weekly, 5, 7, and 9, and he got a graft and patient survival similar to non-synthesized at 1 year follow-up. And the second study, which is the Vienna protocol, using another expensive procedure, which is the immunoabsorption. But this is very nice because you do just one single immunoabsorption session before doing this, and you may reuse this colon for many times. And he used serial 5 to 7 immunoabsorption, giving this induction and this high risk protocol, and chemical reactive antibody 40% or more, number 68, and the results are good. The Toulouse protocol, presented by Lionel Rostand when he came to Egypt, and it is actually the same process like in Sidar Sinai. They give -40, they give one injection of IVIG. At -30 and -15, 2 rituximab. 3 immunoabsorption, 17, 16, 15, minus 3 other, 12, 11, 10. If the MFI is less than 3,000, go on to ETG induction and high risk protocol. T-reg cells, very recent article, now or never. The case for cell-based immunosuppression in kidney transplantation. Is it we need more time to do in animals or we should practice in humans? I hope Dr. Gamal Saadi was here because the conclusion of this was the following. We don't have time to use in humans. This is the conclusion. The possible benefit to patient is weighed against the potential risk of cell-based immunosuppressive therapy. It is concluded that the safety of cell-based immunosuppressive therapy will not be greatly improved by further basic scientific and preclinical development. Only trial in humans can now tell us whether cell-based therapy is likely to benefit kidney transplant recipient, but this should be conservative in design to minimize any potential harm to patients. So he has now a very strong evidence from the Kidney International by this journal. How can technology improve the patient outcome? All of us, we use the net for research. The patient now do patient monitoring tests, but we can do an app for the transplant patient and another app for the physician, and what we call personalization of the care. So this physician has on his computer all the parameters and knows which patient has got a red tag or alarm. And on the patient side, he puts on his data, the serum creatinine, hemoglobin, leukocytic count, C-reactive protein, trough level of immunosuppression, weight and systolic blood pressure, and he gives these to that physician. And they can interact with each other, and whenever there is an alarm or a red tag, he tells him, please come to me, you are in danger. Again, another technological advancement, which is the non-adherence, which is a very important cause of graft loss, and digestible sensor improve, of course, the adherence. Another improvement is the 3D integrated organ printing system. I will discuss this in detail next week during the result, but this is an example of it. This is a cartridge that has been done by the bioprinting, and the problem of this process is that vascularization of the printed construct is a key issue up till now. Transplantation of autogenarians, people over 80 years. Is it madness or not? Of course, in Norway, it is not a madness. They already transplanted between 1983 and 2013, 42 patients, and they conclude it is okay. An estimated 5-year survival rate of 50% for an 80-year-old patient is quite good. And these are the curves for those very old people, very comparable to those who are a bit young. Now I will, in the last few minutes, I will leave the transplantation and I will go to the kidney, and this is the word kidney in all languages. Because these 3 items that I selected are very related to transplantation. The progression of diabetic nephropathy, the reduction of cardiovascular events, which is the one cause of death in transplantation, and how to optimize dialysis before transplantation, and thus there is a safety index an event. Let's go with the Hany test. What is this? Christopher Murray, in his opening in American Society of Nephrology, explained that this DALI, which is a disability adjusted life years, which is equal to the years of life lost due to premature mortality before 86 years, by the way, plus the year lived with disability, and in combination of this is a negative parameter for health. It's called the DALI, or the disability adjusted life years. And this is a positive marker, I mean living well, healthy life expectancy, or HALI, and we cannot say that our patients are only surviving. They should be surviving with Hany, not with that. Okay? And he mentioned that all over the world, they can put, this is the statistics of 2013, global. They show here the communicable diseases, and here they show the traumas and the accidents in green, and here they show in black, in blue, the metabolic diseases and the different, like the diabetes, and they found that the incidence of diabetes mortality in the world now is 2.3%, but it is expected in 2050 to have 1 out of every 3 Americans having diabetes. Regarding the chronic kidney disease, 4-fold increase in the next 25 years, because diabetes is a very important cause of it. Another state-of-the-art opening was the fantastic role of exercises in improving the cellular mechanism of insulin resistance. We know that the cellular mechanism of insulin resistance, when you take much calories, there is defects in the adipocyte fat acid metabolism, and this there is with aging and with inherited factors, defects in the mitochondrial metabolism, and therefore you get insulin resistance. But even single bout of exercise that we don't do will shift this. The glycogen will increase in the muscle, the liver triglyceride and the de novo lipogenesis will decrease, and this patient may, diabetes state may improve. So please go after this talk to exercise. Elevation, what are the markers that you know? Which diabetic patient will become a diabetic nephropathy? I will just mention 2 of them. This study, elevation of circulating human necrosis factor receptor 1 and 2, increases the risk of end-stage renal disease in Caucasian and also in American Indian followed for 10 years. And this is the second study, a panel of 14 biomarkers. You can see them, beta-2-microglobulin and antitrypsin. Some of them you know and some we don't know. Fibroblast factor. If the patient, in these summit investigator studies, have these 14 biomarkers, he will get diabetic nephropathy. And this was in 154 patients versus 153 controls. Among 207 biomarkers, these were the highest of significance. Again, you may go for this urinary metabolomic, which is more expensive, but this specific metabolomic, 2-acyl-3-OH gluconate correlate very well with fibrosis. Now the epigenetic, and there was a debate yesterday that where is the epigenetic is. This was the plenary in the Cape Town, mentioning that epigenetic is transmission of characteristics across cell or organism generation without changes in the DNA sequence itself. Heritable trait of this kind might be influenced by the environment. From the same genome, multiple cell types develop, and the importance of this in humans that there is here CH3, which is cytosine methylation. And you see here the cytosine methylation of the diabetic nephropathy is different, of the fibrosis in the kidney is different from the normal. So methylation determines fibroblast activation and fibrogenesis in the kidney, as you see in this curve. Another important plenary is reducing the cardiovascular events by addressing not only the statins and the ezetimibe to lower the LDL, but the PCSK9, and this is its mechanism of action to lower the LDL, and they found that women who don't have this can live longer and is protected for them. So it has been approved after this Osler study showing decrease by 51% of the incidence of cardiovascular events. Therefore, in 2015, the FDA approved 2 drugs, erlokumab and evolocumab, which are antibodies against this. And in 2018, these 3 other agents, final studies will be released. How to optimize hemodialysis? This is a talk that I gave in London. And last slide, the renal resistivity index that all of us use as a routine to detect a problem in the graft nowadays is determined by arterial inflow and interstitial pressure within the renal capsule. So it has been suggested to serve as a surrogate measure for assessing renal interstitial damage and arteriosclerosis in simple renal patients, not transplanted patients. And if you find that the patient had a resistivity index more than 0.7, his hazard ratio is increased to 1.29. Thank you very much. وهذا سلايد واحد اللي هو سمري بس هو ملخص اللي انا قلته.
Thank you very much, Professor.
You mentioned about the subclinical rejections and the importance of it. Do you advocate for protocol biopsy? Because as far as I know, there is no head-to-head double-arm study between protocol biopsy and biopsy on demand to be sure about the cost effectiveness and clinical background, not only bench.
According to the new biomarkers that may detect subclinical rejection early, I would advocate for doing.
Yeah, but we don't have any clinical implication for it. That's my question. Except if I'm not aware.
Yes, but I was telling that there is a 30% incidence of venous fibrosis or IFTA in around 8 tables studies published in 2015. So according to this piece of evidence, 1/3 of your patient, if they have this, will progress to IFTA.
So after this information, all your patient is completely normal, are you going to do a protocol biopsy? That's the question.
No, I will do markers, biomarkers, like
donor-specific antibodies also.
Yes, I can do the CD, the monocyte marker, or I can do the complement 3. I mean, a group of biological markers rather than. But I can do biopsy and do this immunohistochemistry for antifibrillin, for example.
Okay, thank you very much, Professor Hany.